Good morning, everyone. We are 1 minute past 8:30 on the East Coast of the United States, so we will get started with our webinar today. If you'd like to introduce yourself in the chat box, we would love to see where everyone is from. And we're excited to get started. So welcome to our webinar today, No Health for All Without Gender Equality, Sustaining Momentum on Girls' and Women's Rights in Universal Health Coverage. My name is Courtney Carson, and I will be your moderator today. I'm a Senior Manager for Policy and Advocacy with Women Deliver. I'm also pleased to help represent the Alliance for Gender Equality in UHC, along with the other presenters on the webinar today. The Alliance for Gender Equality in UHC is a group of more than 100 civil society organizations from over 40 countries that come together to advocate for gender equality and sexual and reproductive health and rights in the design, delivery, and financing of universal health coverage. We're so excited to have so many joining us today, and we can see our participant count is already over 100, so that's fabulous. We're looking forward to a really great conversation about how we can continue momentum and accountability for gender equality and SRHR in universal health coverage. As many on this webinar know, last September, the UN adopted a political declaration on universal health coverage, and thanks to the efforts of many advocates and partners, the declaration was grounded in gender equality. The declaration reestablished commitments to universal access to sexual and reproductive health, rights, and information. It committed to advance gender-responsive health services and recognize the distinct role and contribution of women in the health workforce. It promoted women's participation in health leadership and governance. And importantly, the declaration made it clear that without considering the unique health needs of women, girls, and marginalized communities, the promise of UHC will not be realized. Today, we'll discuss what's happened since September 2019, and we'll hear from advocates working at the global and national levels to maintain momentum and critically hold governments accountable to UHC that upholds gender equality and SRHR. Before we start with that discussion today, I do want to take a moment and recognize the unprecedented global health emergency we're in right now and reflect on the COVID-19 pandemic that will undoubtedly have significant implications on our health systems. At the highest level, this pandemic really underscores the vital importance of investments in health and the continued need for strong, robust health systems equipped with health workers, appropriate technologies and supplies, and clear public health policies for pandemic preparedness based on prevention, detection, and response. It's clear that this pandemic is testing health systems around the world, and even countries with strong UHC systems are being strained and stressed. While we're still learning about the virus, we do know also that it will have unique and distinct impacts on girls and women. Women make up 70% of the health workforce, which means that women are on the front lines of responding to this pandemic. It's essential that female health workers be trained, resourced, and equipped to effectively respond, and this includes equal pay and addressing the 28% gender pay gap in the global health workforce. We also need to better understand the biological impacts of the virus, which means the world needs to invest in timely collection of gender and age disaggregated data in all disease surveillance and monitoring efforts, in addition to gender-sensitive R&D for therapies and vaccines. In crises, the most marginalized communities tend to experience disproportionate burdens in access to health services, treatments, and resources, and this is likely to be the case in the COVID pandemic. From past epidemics, like the 2014 Ebola outbreak, we know that in times of crisis, funding for essential health services can be diverted. This often disproportionately impacts women's health, and in the case of Ebola, this directly led to an increase in maternal mortality. We also need to acknowledge how traditional gender roles shape how different people of all gender identities and backgrounds will experience COVID-19. We know from past health emergencies that women's traditional role as caregivers for family members often increases their exposure to infectious diseases. And with schools closed around the world, women are hit particularly hard, as much of the responsibility for child's care still falls on them. Strong gender-responsive health systems can help mitigate risks to girls and women during the COVID-19 response and in the future. And we firmly believe that UHC structures that apply a gender lens will be an important cornerstone of building gender-responsive health systems. So this makes the conversation today even more timely and critical, and I'm excited to get into our formal program. So as we transition, I want to thank you all again for joining. I'm so pleased to hear from Eleanor Blomstrom, Senior Program Officer with the International Women's Health Coalition, SM Shaikat, Executive Director from SERAC-Bangladesh, Faridah Luyiga Mwanje, Program Officer with the White Ribbon Alliance in Uganda, and Deepa, Director of the Sama Resource Group for Women and Health. These advocates will tell us about how they're championing gender equality in UHC and strategies that are showing success at the global and national levels. We'll hold all the questions until the end of the presentation, but please send us your questions throughout the webinar using the Q&A function. Please don't use the chat box as it gets a little hard to scroll and we can better keep track of questions in the Q&A function. And you should find this at the middle bottom of your screen. If you're engaging on social media, we'd love for you to use the hashtag GenderUHC. There'll also be a quick survey at the end of this webinar, and we thank you in advance for completing it. It should pop up right when you click out, but we'll also circulate it in the chat box as well. So with that, I'm happy to turn it over to Eleanor to highlight advocacy and momentum for gender and UHC at the global level. At the International Women's Health Coalition, Eleanor works on international advocacy and policy to ensure gender equality and sexual and reproductive health and rights are prioritized into global policies and programs, particularly focusing on UN agencies and processes. This builds on her years of experience at the Women's Environment and Development Organization, where she led global-level advocacy in UN processes, including climate change, disaster risk reduction, and the 2030 Agenda for Sustainable Development. She has experience facilitating alliances of women's rights and feminist groups and driving diverse coalitions. We're so glad she's with us today, and thanks, Eleanor. Over to you.
Thank you so much, Courtney. It's a real pleasure to be taking part in the webinar today. I think it's very timely, and I definitely appreciate, Courtney, that you brought in some of the information related to COVID-19, because I know we've seen so much in the news about the lack of a gender perspective there. And UHC, I think, is one of the ways that we can rectify that situation going forward. So Courtney gave a good introduction, and I just wanted to make sure that when I'm talking about how we're taking rights-based global action, how we've done it in the past and how we're doing it going forward, what is making sure that we're all on the same basis of understanding what UHC is. I'm sure everyone on the call knows this, but for me, the easiest way to think about UHC is to look at the 2030 Agenda for Sustainable Development, which lays out in Target 3.8, which is SDG Goal 3, to ensure healthy lives and promote well-being for all at all ages. It lays out 3 different aspects of UHC, which is 1, financial risk protection, 2, access to quality essential healthcare services, and 3, access to safe, effective, quality, and affordable essential medicines and vaccines for all. And one thing I do want to point out is the fact that the goal in the SDGs is broader than UHC and includes things like sexual and reproductive health services, and so much more, is a strong result of advocacy from women's rights health experts and many others. So just goes to show how even laying out the basis of UHC and as part of this broader issue of health really comes from the action of women's rights activists and advocates worldwide. Next. So how did we get to this political declaration on universal health coverage and the high-level meeting? It was a fairly long road, and some of you may be familiar with it and others not, depending upon the level at which you're working. But there are a number of steps leading up to the high-level meeting. for years, there have been global health and foreign policy resolutions. And in 2017, the resolution that's is a General Assembly resolution at the United Nations, it called for this high-level meeting. And then later in 2018, it's an annual resolution, and it laid out the modalities for the high-level meeting under the theme of universal health coverage, moving together to build a healthier world. As I mentioned, the Sustainable Development Goals had already in 2015 laid out some of the aspects of what UHC is, and also included a call for universal access to sexual and reproductive health as well. And in the past years leading up to the high-level meeting, there were a few key steps. One was the multi-stakeholder hearing that took place at the United Nations in April 2019, before the process for negotiations really started. And I think it's important to set out at this point that that was really the one place where the process was open to civil society. Otherwise, the negotiation process was closed, and it took a lot of advocacy work to make sure that we were well aware of what was going on in the process. But it was a very exciting hearing. There were people, some who are on the phone, on the webinar now, and many others who are listening were at the hearing and making statements and interventions at that point. Additionally, things that aren't on the slide are the Astana Declaration on Primary Healthcare in 2018, which is very a foundational aspect of UHC. And of course, there are national level policies that existed, and I think we'll hear about some of them, and maybe you'll have information to share in the discussion as well. The negotiation process was actually quite interesting, and I'll tell a few more highlights of that later on. But it began in May of 2019 when the co-facilitators released a zero draft. And in that same month, the World Health Assembly adopted a resolution that mentioned UHC. Throughout the year May through September of 2019, there were negotiations that took place in kind of 4 major rounds of negotiations. And interestingly enough, it was expected that the negotiations would end in July, leave a summer free, and then come to have a celebratory adoption of the declaration in September, which didn't actually happen. The negotiations went much longer into September. Then we have the high-level meeting itself on UHC, which adopted the political declaration on September 23rd, 2019. And this was really important. I mean, the political declaration itself, the goal was to make a strong political statement about the urgent need for universal health coverage, and also commit to taking action by governments. It was supposed to provide a general outline of what UHC is, what it includes, but it wasn't really meant to be a blueprint for how to carry out that action at national level. Primarily more, it was meant to be guidance and broader commitments to be adapted to national realities in order to implement it strongly. Leading in this process, I've mentioned some of the key actors, but it's important to know the President of the General Assembly was really leading the process together with the World Health Organization, and governments were the key protagonists. It's a government-led process with co-facilitators from Georgia and Thailand. And then there was a group of friends of UHC led by Japan, but several other governments, and multiple groupings of governments negotiating together. There were also the UHC 2030, which was it's a multi-stakeholder platform of governments, UN agencies, and civil society. Then there's a civil society arm of that called the Civil Society Engagement Mechanism. And on the slide, it talks about 6 asks and priority actions. And these are different documents that were put out to really say, here's what we're looking for from UHC. And then we get to the Alliance for Gender Equality and Universal Health Coverage, which also put out a number of really important advocacy documents, which I'm sure many of you have seen and many of you contributed to, that included a 7th ask specifically on gender equality and women's human rights, policy priorities, and we worked through a lobby week and multi-level advocacy, which was absolutely crucial. Next slide, please. The political declaration itself, Courtney highlighted, I think, a few of the outcomes of it. And there are three things that I put on this slide in particular. One is that it reaffirms the right of every human being, without distinction of any kind, to the enjoyment of the highest attainable standard of physical and mental health. And this is crucial at the outset. Another piece that's important for the Alliance and for gender equality generally is that it talks about engagement of women in the workforce. And we know that women make up 70% of the health workforce, often at multiple levels, but many are working at a lower paid, less recognized level. And it's really important that this document sets out ways to fix that situation. And then finally, what was one of the most contentious aspects of the entire process was sexual and reproductive health and reproductive rights. And getting to this paragraph that you see on this page was not an easy task. There was serious pushback. So the fact that this is here is an incredible testament to all of the people who are working in the women's rights advocacy process and to the leadership of the feminist movement. So really, I mean, this is a first of its kind global agreement, really advancing progress. And we need to take it as a starting point, but not an ending point by any means. There's so much more that could be done with the basic language we have in it. Next slide. So the Alliance for Gender Equality and Universal Health Coverage is, you can see at the bottom, the co-conveners, and I'm really excited to say on this call that we have two new national level co-conveners who are Spectra Young Feminist Activism from Rwanda, and then Sama Resource Group for Women and Health from India, who are actually on this call speaking later. And what the co-conveners previously had been International Women's Health Coalition, my organization, along with Women Deliver and Women in Global Health. And in this phase of implementation, it's really critical that we have a strong link to the national level and are working to engage across regions to ensure implementation of this political declaration. So the Alliance itself was founded in March of 2019. You can see that the goal was to drive collaboration and coordinated advocacy for gender responsive universal health coverage, policies, programs, and dialogue. And this included, but is not limited to sexual and reproductive health and rights. And we started March of 2019 with a meeting of about 10 people, and by September had grown to over 100 organizations. And today we have 116 organizations from 49 countries. But the growth in the beginning of the process for the UHC was phenomenal. It really showed that there was a hunger and a missing piece in all of the advocacy and civil society work, as well as governmental work around UHC. What we were missing was a focus on gender equality, a focus on women's human rights, and the Alliance filled that gap and filled it with energy, diversity, and really very extreme impact. So I'll talk about that in the next slide. So as I mentioned, we had a meeting in March 2019 in New York. And then after that, there was rapid growth. And it was a real example of feminist leadership coming together out of a need. This wasn't something that had been planned for a long time in advance, but multiple organizations, not just the co-conveners, saw that there was some reluctance on the part of other groups to take on gender equality, and especially sexual and reproductive health and rights, because it's often seen as controversial or contentious. And it may be, but it's also absolutely critical and underpins universal health coverage and achieving health for all. So with the feminist leadership of everyone in the Alliance, there was a long road of rights-based advocacy. We hosted a lobby week in New York in July, where members met with government delegations from their countries and other countries and brought forward a number of the important points from the Alliance. There were action alerts sent out so work could be done at national level and beyond, statements, social media. And the challenges that were faced were, like I said before, closed meetings and pushback on sexual and reproductive health and rights by both government and civil society, and this really strong anti-gender and anti-human rights groups of governments who were trying to keep out any mention of human rights from the document and anything related to sexual and reproductive health and rights or anything about those services. But really the success, I don't want to dwell on the challenges, those exist, and it is the world we live in, and it's something we need to continue fighting against. But a success is that we had a large number of ally governments who made joint statements that clearly showed the strength of the support for gender equality, women's human rights, overcoming gender barriers, ensuring that sexual and reproductive health and rights underpin UHC, that gender in the health workforce has to be addressed, and that UHC is fundamental for achieving gender equality and women's empowerment. Not to mention actually bringing in language of UHC across the life course, which means that it's addressing adolescents, it's addressing older women, it's getting at those people who are not necessarily captured in the statistics, and ensuring that they will be captured in statistics and acted upon and with in the future. Next slide, please. This is just a picture of the celebration at the high-level meeting. I wanted to show the joy in the room. Next slide. I know that there've already been some of the resources shared in the emails going out, so I'm not going to dwell on this one, but this is really where our key asks came from. I've mentioned most of these, but a few of them that I haven't dwelled on yet are the addressing determinants of health that drive risk and ill health for all genders, and really thinking about equitable financing systems that can minimize the burden and out-of-pocket payments that women face. Women often don't have the same access to insurance or health coverage, and so there needs to be specific gender responsive views on that. And also, well, let's just go on to the next slide because I think I'm running out of time. All right, so there are opportunities, and then we can take all of this work forward, and some of them are a little bit uncertain because of COVID-19, but that doesn't mean our work stops. We just have to change how we do it. So the World Health Assembly is coming up in May. It may be virtual, it may be delayed, but it's a moment to continue to act, to build upon what we have in UHC and really think about this as the year of the nurse and the midwife and what action we can take. So I look forward to working with you on that. The high-level political forum is where the SDGs are looked at for in terms of accountability. And in some years there have been focus SDGs. This year there are not, so health and gender equality and women's human rights can be cross-cutting. Really exciting opportunity is Beijing Plus 25, and I've just put 2020 here because we're not quite sure when the Generation Equality Forums will take place given the situation, but there are action coalitions. And in particular, I'd like to point your attention to the third one, bodily autonomy and sexual and reproductive health and rights, and how this is a space, it's an exciting new kind of space that is more open, and the idea is that these are led not just by governments, not just by UN agencies, but by feminist leadership, really taking action and driving this process. So I encourage everyone to look into it and to get involved and join some of the other coalitions where we can work together. The UN General Assembly will have a high-level meeting on Beijing Plus 25, so that's another opportunity. And then there continue to be work on the global health and foreign policy resolutions, which is a little more wonky, but it is exciting for those of you who want to be involved at that detailed level at the UN. And I would encourage you to reach out to anyone on this call or to join the Alliance, which will send that joining link again, just to make sure you have an opportunity to do so. Next slide. So again, without women, it's not universal health coverage. And that means women as leaders, women accessing healthcare, women not having a burden of out-of-pocket payments. And this is women in all their diversity. women and girls across the life course. So I thank you for your time and look forward to the discussion.
Thanks so much, Eleanor, and thanks for both looking back at what the Alliance was able to accomplish through advocacy last year when we all came together with common goals and purpose, but also looking ahead at what some concrete opportunities are for us to continue to work together to keep gender and UHC on the policy agenda in 2020 and beyond. It was really great to hear that. Next, we are going to turn to Shaikat. SM Shaikat is the Executive Director of SERAC-Bangladesh, a youth organization advocating and implementing programs on access to family planning, reproductive health rights for youth, and prevention of child marriage and gender-based violence in Bangladesh. He's worked with a number of global youth agencies, including as a Women Deliver Young leader and as an ambassador for Young Men for Gender Equality. Most recently, Shaikat has been awarded the 120 Under 40 Global Family Planning Leadership Award by the Gates Institute. We're so pleased to have him with us today, and Shaikat, the floor is yours.
Thank you so much, and thank you for having me on this webinar. And I was really moved by the presentation we had just before my presentation, and it is exactly not something that is very distinct from the previous one, but relating to the global dialogue and the momentums happening everywhere. And I'm just going to give you a little more information about what is happening nationally, like in the local context in Bangladesh, what as smaller organizations can make a little impact to the global commitments and how it can enrich the dialogue everywhere. So the first slide, if you look at, there is like a bunch of young people, just like hundreds of, and just to adjust the picture, I had to crop down a few faces, but there were a lot more. It was a huge gathering. So I'll move on to the next slide to tell you in detail. So it was in 2016 when, right after the SDGs, Sustainable Development Goals, were undertaken by the United Nations, and Bangladesh started its 7th 5-year national plan. So it's every 5 years the country adopts one plan for its financing, policy, strategy making, and every other development investments, including health, of course. So what happened, like the years did not much match. For example, the SDGs were in like 2015, and then the national plan came in 2016. So with this 1 year's gap, like the government had to adjust a few things with the SDGs and the national plan between them. So and we studied that, and we found there was a lot more lot more gaps than the policymakers were chatting about. For example, they were talking about there's effect like a lot of participation scopes, and stakeholders can engage to create spaces for dialogues on universal health coverage and blah and blah. But the one important point was missing, which is the roads for participation were not indicated, or there was no indication where, to whom, how this dialogue will be generated, or how young people who are who contributes to 30% of the country's population can be a part of that. Because earlier the UHC was used to be like a T4 the researchers, the economists, and the academicians, rather, or the health professionals. But where do these young people come in, or any other stakeholder groups? This was not much discussed, or there was not much space. So we felt that this is a momentum, because this is the year for the national 5-year plan, and we can really hit this hard with the proposal that this is one stakeholder group that need recognition. And we started advocating with the government's department that is responsible for UHC, which is the Health Economics Unit of the Ministry of Health. But later we understood that, we need to actually have some sort of forum or like a participatory approach. So that gave us an idea to host a national summit, which we took place in December 2016. The idea was supported by the Universal Health Coverage Coalition and Global Health Strategies. We're very thankful to our partners. And SERAC took the lead in organizing that, and many other partners, including Gender Health, USAID, and many other band partners, they joined us and made it successful. So with the 150 young people, and essentially I should mention with 70% female representation in the participation were ensured, because we gave it priority that the health workforce everywhere, not just only in Bangladesh, everywhere in the world, is led by women, and it is a vital condition that we need to ensure their voices there. And we brought together young nurses, doctors, medical students, lawyers, engineers, and everyone. Like, that was really something difficult, but the background gave us the opportunity to hit the momentum. And before I go to the next slide, I'm going to give you a brief about the countries, some of the challenges that we are facing at this moment. Bangladesh, as you know, is a country with a lot of opportunities, but we also have a few challenges related to the universal health coverage. Three of the most identified challenges include the lack of resources for health. For example, like this, at this moment, for COVID-19 response, the country is really experiencing a very, very hard hit, because a lot of shortages of resources, lack of PPE for medical professionals, and lack of facilities are also a case, because this is the ICU in the entire country is like is still a two-digit number. And also the second challenge that was identified is the out-of-pocket expenditure. What the poor people everywhere in the world are suffering, and Bangladesh is not different from that. But this out-of-pocket expenditure is really making difficult the life of the people who earns very little, or they live daily life based on small jobs. So that portion of challenge is yet to be reduced. And the third one, but the most important as well, which is the efficiency of the use of the resources. Because there is a lot of investment and policy and strategies are there in place, but then the efficiency of using them are still a big challenge for that. So today, when Bangladesh is actually having the struggle for COVID-19, we are also preparing for the 8 5-year national plan, which is to be started from next year until 2025. And it is to mention that we are also running under the 2012 to 2022, which is a 10 years long healthcare financing strategy. But this is look at the words, the strategies, the plans. These are the words that doesn't give much legal bindingness for the state to move forward to fulfill the SDG 3.8 targets for the country. So let's move on to the next slide, so I can tell you how we wanted to engage more into this process. So to organize that summit or a forum to give people, the stakeholders, a buzz that there is a group that you are missing in your dialogue. So we had a plan of action to organize the summit, but also what topics to be discussed. For example, the quality of medicines to be discussed, SRHR, which is often not given priority by the economists during the universal health coverage discussion. We brought that on the table. We also brought people who were not, given attention. For example, the LGBTQ community, and also the healthcare professionals, especially the nurses, the midwives, who play a very important role in the system, but they are neglected due to because this is like a doctor-dominated health system in the country, and everywhere they plan the strategies where other health professionals are not even treated like their proper healthcare professional. This is the reality. So we brought together everyone on the floor, and then we were really we didn't expect, which is going to be the biggest challenge for us to do that, which is the resources, like, for example, the funding, the information, the people, the communication, and of course the participants who need to be qualitative, because these are the people who will speak up and who will raise the issues, who will take this away with them, after the summit. So we are really happy that we were much supported by the UHC Coalition and JAC, as I mentioned before. And also there's some local funding, including SERAC's own resources. We mobilized to, host that a day-long summit. And we connected across all big cities and and smaller towns to receive nominations from the young people's groups, and which was really amazing that a lot of nominations came, but we could, due to limitation of the spaces and resources, we could only host 150 of them. And then the summit came on Universal Health Coverage Day on December 12, 2016. It was not just like a usual event, which is like people come and go, eat and sit, but this was a space where the parliamentarians, the policymakers, the people who designed the National 5 Years Plan or works on the healthcare financing strategy, who designed them, they were on the floor, and they were really amazed by the concerns raised by the young people, and they finally recognized that these are the people we're missing. And it's not just universal health coverage is not just like a cake for the people who sits on the top, but it's for food for thought for everyone, and everyone can contribute to that. So that was the beginning of this journey, I think. And later, if you can look at the last circle, which includes the BHAN, what is the BHAN? I'm going on to the next slide to tell you in detail. Next slide, please. Okay, so Bangladesh Youth Health Action Network, which is in short BHAN. So it was an outcome of that summit, because a lot of the young people, they really wanted to stay connected, but with a purpose. And what was the purpose? To to bring up the issues, to take action, to remind the policymakers. So, for example, if we look at the UN political declaration that was adopted last September, it really from the zero draft that we engaged, and until the final one, we have seen a certain topics that was highlighted. For example, the governance and participatory approach, the mainstream in gender equality, or even like a strong health and social workforce. That was really important. So the social workforce was created by this Bangladesh Youth Health Action Network. And then finally the follow-up mechanism, that was really something. Everywhere we talk about a political declaration or any other commitment, there is a follow-up mechanism which requires it to be enforced, or like to be reported like it's not being followed, or like whatever. So this is a great concern as we look at the government's commitments around universal health coverage, because the follow-up is a burden traditionally rested upon the civil society everywhere in the world, and which we find really a credible point to start our work with. So we supported, like SERAC supported Bihan as a secretariat since the beginning, and with information, with resources, with chairs and tables and everything it needed. But of course, the most importantly, the regular day-to-day information transmission, that was most important. And we also tried to expand that network. So we went to the smaller and bigger everywhere, all the cities, and the local level, the like the rural areas as well. So we did through the campuses and other education institutions or the community-based youth groups who became the members of the network, and currently they contribute to over 300 young people across the country. So we really wanted to have the social workforce that could follow up this kind of a political declaration or the country's national plan of action, and probably next year, which is the 2021 to 2025, the national plan. We really are looking at the momentums where we can sit with the planning commission to discuss where the young peoples are concerned. For example, like within the last 3 years, the network organized a lot of activities, including, if we go to the next slide, please. I'm just continuing my, yeah. So the actions that we can see is this is one campaign that on 2017, right on the first year of this inception, we organized a national level stand the clock campaign. So like we considered the clock stopping on 12/12 on 12/17. So it's like 12 past noon in the 12 December in 2017. Everywhere in the country, young people stood up along with medical professionals, policymakers, academicians, to give the policymakers a message that yes, it's time that you consider this is universal health coverage is a right, and it's the right time to invest in right thing. And in 2018, can you go to the next slide, please? Yeah, I'm just considering my time shortage. Okay, so so reaching the high tables, for example, that was a really a dreaming thing, because how we reach the high tables, we have all the local level networks, but then we also made good communication with the Director General of the Health Economics Unit, and as with the last 2 years advocacy, it was a bit easier for us to get him on floor. And we also passed on the agenda to the parliamentary candidates, because it was right before the national election. So this is how this network, like used the momentums of advocacy. And currently, the network is looking at the opportunity to engage into the 5-year plan, which is going to be adopted next year. So
thank you so much, Shaikat. I know you have so much more to say, but I do want to make sure that we're able to transition to our other speakers. It was so great to hear both about how you helped to mobilize youth voices before the high-level meeting and the steps that you've taken afterwards to make sure that voices are continued to be heard, and you've moved from a one-time national forum into a structure that's more sustainable and has continued influence with policymakers in Bangladesh. And I know that there are many questions that will be coming your way in the Q&A. So thank you so much, and sorry to cut you off. But I want to make sure that we have time to hear from Faridah. Faridah Luyiga Mwanje is Program Manager at White Ribbon Alliance Uganda, where she leads implementation of UHC for Me. UHC for Me is an advocacy and social accountability program to improve quality, equity, and dignity at the point of service delivery and influence long-term system-wide change for priority populations through national and subnational UHC planning, policy, budget, and implementation processes. Faridah has organized citizens' hearings on accountability for reproductive, maternal, newborn, child, and adolescent health at various levels. She also has experience driving social accountability with global decision makers, including for the Global Strategy on Women's, Children's, and Adolescent Health. Faridah, we're excited to hear from you, and the floor is yours.
Thank you. Good morning, good afternoon, and good evening. It's a pleasure to join you to share with you how we are advancing SRHR and gender equality in UHC, and we'll take a closer look at the What Women Want and the Universal Health Coverage for Me programs in Uganda. Next slide. Generally, in Uganda, there have been several commitments, policies, and plans that have been made to ensure provision of sexual and reproductive health and SRH information and services, and also promote gender equality and achieve universal health coverage. But we've also seen, yes, steps in the right direction. There are also challenges in bridging the policy to implementation gap, which has left several women and girls in need of comprehensive sexual and reproductive health services. And when you look at the picture generally, you will see that the teenage pregnancy rate stands at 25%, and it has stagnated between 24 and 25 in the last decade. We have skilled birth attendance at 74%. Although this has increased, it hasn't translated into a corresponding reduction in maternal mortality, which is at 336 per 100,000 live births. We have a high unmet need for our family planning, and at the ICPD recently in Nairobi, the president committed to reduce that from 28 to 10% by 2022. We are also struggling with issues of female genital mutilation. Women and girls in Karamoja and also Sebei regions continue to be at risk of female genital mutilation. Though this is banned, it exists, and the national prevalence is at 1.4%. And doctors are critical in providing SRH services. When you look at our doctor to patient ratio, it stands at 1 to 28,000, which is far below the WHO recommended standard of 1 to 1,000. So far, it looks like doctors in Uganda have a workload that is 28 times more than what is humanly recommended by the WHO. And when you look at the refugees, we host the biggest number of refugees in the African continent. And we know that refugees tend to have, or displacement tends to come with risks of defilement, rape, and other forms of gender-based violence. Next slide, please. There have been several advocacy efforts to ensure, SRHR and gender equality in UHC, and I'll highlight a few of those. We've had the National Sexuality Education Framework. The photo there shows the First Lady and also Minister of Education and Sports launching it. It was launched in 2018, but we're still working towards realizing this. Prior to that, there had been a ban on sexuality education in schools. And there was a lot of social media uproar about explicit content that was found in one of the schools. And there were so many calls for accountability. The government asked the ministry to explain, and they created a framework to ensure, or to guide the provision of sexuality education in schools. So apparently, during the ICPD, the president committed to to operationalize this framework, and all the various assessments have been done, the regulative impact assessment, and this has been submitted to cabinet for endorsement, awaiting approval. That is a big step in the right direction. We've had delays here and there, especially backlash from the religious community, who felt that they were not consulted enough. And of course, the church was at some point very categorical in telling all mission-founded schools not to teach sexuality education. But consultations have gone on along the way, and everyone is on board, and we're moving in the right direction. Then there has been the National Health Insurance Bill, which proposes, among other things, to establish a national health insurance scheme to Uganda. We know that national health insurance schemes are some of the smartest ways of achieving universal health coverage. This bill was tabled before Parliament for its first reading in 2019, that was last year, despite the fact that discussions have gone on for the last more than 17 years, and notions of the bill have slowly evolved over the years. So this bill intends to facilitate the provision of accessible, affordable, and qualitable health services to citizens, irrespective of their age, economic, health, and social status. But we've had, setbacks, and the most recent development when it was presented, the president tasked Parliament to put it on hold. But as advocates, we put our ear to the ground, and knowing the current political environment, maybe there are challenges of passing it at the moment. But we are continuing the discussions around the same. We've had the universal health coverage roadmap for Uganda, which will outline the exclusive steps for Uganda to achieve UHC by 2040. This is still in draft form. We've also had engagements around the health worker migration policy. It's also in draft form, but to regulate the movement of health workers within and outside the country so they're able to provide the needed health services. There have been other advocacy engagements around advocacy on other commitments, FP 2020, the sharpened plan, and so many more. But as advocates, we believe that yes, most of these commitments are coming to an end this year, that is 2020, and it provides an opportunity for us to engage the various stakeholders and also remove the bottlenecks to ensuring that women and girls access sexual and reproductive health services and information. Next slide. At White Ribbon Alliance, we realize that it is important to ensure that policies and plans that reflect the self-actualized needs of women and girls are implemented. So we launched the What Women Want campaign, and it was about ensuring quality reproductive and maternal health care for women and girls. This was a global campaign, and in Uganda, it targeted 90,000 women and girls between 15 to 49 years. And the responses that have come out from all the districts show that reproductive and maternal health care in Uganda is not meeting the needs of the women and girls. And we've also ensured that women and girls who are marginalized, such as those in refugee settings and those affected by FGM, are part of this campaign. Why did we decide to use this approach? We know that for women and girls to receive qualitable, equitable, and dignified care, we need to know what quality means to these women and girls for us to be able to achieve the related SDGs and also universal health coverage. So that is why What Women Want was asking women what is their priority request for quality reproductive and maternal health care, and different women had different views. Next slide, please. So when you look at the results of the campaign, yes, we've used media to amplify the voices so that they reach the decision-making tables in Parliament and the Ministry of Health and so many other stakeholders. At the bottom, we have the top 3 results from Uganda, which are labor and delivery information, medicines and supplies, and also menstrual hygiene. And the government is already making commitments to utilize this rich wealth of information to inform their plans and policies at the Ministry of Health. And the Minister of Health talked about using this information to inform their plans and policies under the Quality of Care Network at the Ministry of Health in Uganda, which is aligned with the work of the What Women Want campaign. And when the Commissioner Maternal and Child Health responded to the needs to issues of disrespect and abuse, she said that in many health facilities, mothers are beaten, which some health workers think is a way of getting them to be courageous. There's need to listen to women and handle them in a dignified manner while ensuring that they're getting the quality health care. So we're already seeing some of the decision makers, take these results to use them to inform their planning. Next slide, please. So what next? As we move from evidence to action, we're utilizing the What Women Want findings or the evidence to inform our programming. And one of the programs that we've embarked on is the Universal Health Coverage for Me program. This program is designed to improve the UHC principles of quality, equity, and dignity at the point of service delivery, but also influence long-term system-wide change for priority populations at the national and subnational levels through budgeting, policy, plans, and implementation processes. And this program is going to leverage the 90,000 responses mobilized from women and girls under the What Women Want campaign. And as we continue to create that catalytic role, we are focusing our priorities on host and refugee populations in Adjumani and Jumbe district, and also engaging in advocacy at the national level, such that these people are able to voice their interest and also accelerate universal health coverage for these intended outcomes. Next slide, please. And this is our approach. This is how we're planning to create the change through this multi-level, multi-sectoral approach. We have realized impact as a result of using this approach in various campaigns. And over the years, we've learned that when citizens are engaged, they can, through their voice, demand and hold leaders accountable with positive results. At the bottom level, we set our priorities with the community. We know that when you mobilize them, give them information about their rights and obligations, they are able to raise their voices and demand accountability with confidence. So from the community level, we know that the citizens' voice demanding accountability must reach the decision-making tables at the local government level, at the national level, and also the global levels. So we're using various platforms to engage the decision makers. We're using media to be able to bring these voices at that level. We are working in partnership with other CSO stakeholders this is a diverse group of health and rights advocates where we're working to undertake collaborative action and advance shared UHC priorities and agendas. But as we do this, we also work in partnership with champions who are using their powers of influence to talk about these problems and call for accountability. But along the way, we also realize that the problems cut across different sectors or different government agencies. We know that sometimes we need to involve the Ministry of Health, the Ministry of Gender, Ministry of Education, and so many more. So we need to harness and take advantages of the linkages in the various sectors and work on these issues together in a multi-sectoral way. As we go all the way to the national government, we are supporting policymakers to be able to respond to the citizens' demands and also look at the impact of their outcomes on maternal health, or the impact of their decisions on maternal health outcomes. Then we go all the way to the global level. We know that our governments make commitments at these platforms. So we call on to our governments to accelerate commitments or action in their commitments at that level. But as we raise the voices of the citizens to be heard, we also ensure a feedback loop such that people or the citizens know how their voices were used and how they contributed to the impact. So ladies and gentlemen, as I wind up and as I conclude, I would like to remind you that UHC at its heart is about expanding access for those most in need. We need to ensure that those who commonly experience inequality on the basis of income, age, sex, race, or ethnicity, disability, or even migration status are part of the UHC dialogue. At Y2 Born Alliance, we've learned that citizen-led accountability is one of the fastest and most sustainable ways to bring about change. Thank you very much.
Thank you so much, Faridah. It was really good to hear both what the situation is in Uganda and the national policy frameworks that are in place, and how you and your colleagues are mobilizing in 2020, seeing the opportunity as some of the frameworks are either up for renewal or ready for the next phase to really bring citizen voices to the forefront to make sure that the UHC policies are reflecting the needs of girls and women and people who need services. So thank you so much. Finally, I'm happy to introduce Deepa as our last speaker today. Deepa works with the Sama Resource Group for Women in Health based in Delhi, India. She has been engaged for several years on issues of gender, public health, SRHR, and human rights through research and advocacy. She's been actively involved with the People's Health Movement, as well as with other health and feminist alliances. Deepa, the floor is yours. We're looking forward to hearing from you.
Thank you so much, and thank you to all the previous speakers for their inspiring work. Before I begin, I want to express my solidarity with all of you who are joining in this webinar in this really challenging times. And I think never more has universal health care or coverage and gender equality and sexual and reproductive health rights been more relevant than it is today. So thank you also to Women Deliver for having organized this webinar. I'd like to start by pointing out to the first slide where you can see young girls from, these are young girls that we work with from marginalized communities in India. And this is following the Universal Health Coverage political declaration. And these are initiatives to see how we can bring the global discourse to the grassroots. And I'll kind of delve upon it a little bit more as I kind of talk through the presentation. Next slide, please. So just a very brief overview of the context in India. As you know, India is a very large country, has many and very large issues. So I won't go into detail with each of them, but to really begin with, the gender, to start with the health budget. And this is because after the UHC political declaration last year in September, we had a union budget that was declared this year in February. And just to flag that, we actually did not see any increase in the budget. And so, it also kind of draws attention to the fact that regardless of commitments of countries to universal health coverage, there was actually cuts in public investment on health in India. So as of now, and even earlier, we've only seen around 1% of the GDP on health, allocation on health. And this continues to be so for this running year. And this really ignores the National Health Policy of 2017, which kind of really proposed that spending should be increased to 2.5% of the GDP, at least by 2025. This requires that at least 30% increase every year, which we haven't seen at least this year, despite this commitment to UHC. What has really seen some increase is the insurance scheme in India. And the previous speaker, Faridah, spoke about it and about the scheme in Uganda and very positively, whereas in India, we've looked at it more critically because the evidence does not really show decrease in out-of-pocket expenditure, nor is it showing better healthcare. What it in fact is showing is that there is a focus, the focus shifts away from strengthening the public health system. And this is extremely critical. The strengthening of any public health system is very critical, especially to mitigate the implications of gender and other social inequities. And this insurance scheme actually has seen a lot of irrational practice, and it hasn't really shown evidence of reducing out-of-pocket expenditure. And for those of you who are familiar with India's context, you would know that India is one of the countries that has a very highly privatized health system, and that I think data from a few years ago showed that 8% of people were pushed below the poverty line because of expenditure on health. And when you look at a population of 1.3 billion, 8% in absolute numbers is a huge number of people being pushed below the poverty line because they have to pay for healthcare out of pocket. And in this context, therefore, women and others from marginalized communities bear the brunt of the out-of-pocket expenditure and really bear the barriers to accessing healthcare. The other thing that I wanted to flag, that in the budget for this year, we also saw actually, reduction in the reproductive and child health component. It has seen a cut. We saw that allocations for maternity entitlement and wage compensation for women, which is very closely related to their access to healthcare, it remained the same as last year, which in itself was very low. So in terms of the health needs, and this is in a very narrow context that I say that even in this context, in this very narrow context, women's health needs have been completely ignored. The other point I wanted to flag is that publicly available disaggregated data on gender spending has been limited. It's not available in the public domain, and there is limited understanding of how gender-based challenges are being addressed and how the spending translates to gender-based outcomes. The other very important issue, which I think all other speakers have raised, is about health workers. And in India, we have a very large pool of community health workers, nearly 900,000 women, all of them women, who are working across 32 states. And they continue to be paid either incentives or really paltry sums. They are not regular workers. They're not recognized as regular workers in the health systems, and hence do not receive any benefits, nor adequate institutional support. And they work in extremely poor conditions. In fact, currently with the whole COVID situation, there have been reports of frontline workers being attacked because they were playing their, they were pretty much doing what they had to do by reporting, possible symptoms of COVID or people who had such symptoms, and they were actually attacked. And there's absolutely no support, nor institutional nor community support in many places for them. And they are not also provided with the necessary personal protective equipment. And these are the kinds of challenges that they face. And we're talking about the current situation, which of course is almost 6 months after we've committed to the universal health coverage political declaration. I also wanted to talk a little bit about the laws that are, not specific to the health system, but are very closely linked to the health system. And these are very violative laws vis-a-vis sexual and reproductive health and rights, and they violate bodily autonomy and integrity. One of these laws is the Transgender Persons Protection of Rights Bill, which was actually the act which was passed last year in November. According to this act, for example, a certificate of identity is required for a transgender person. So they have to make an application to a magistrate, and that magistrate will then indicate their gender as transgender. And they have to actually go through a medical examination to get this certificate, which is really dehumanizing and extremely discriminatory. Similarly, we've had many concerns with the surrogacy bill, where now surrogacy, it's still kind of, it's seen now as an altruistic surrogacy, so that surrogates will not get paid, remunerated for their services. I know it's an extremely contentious issue, but when it comes to women's decisional autonomy and their right to make decisions about their bodies, it's extremely problematic that we see that altruism as something that is all right, completely ignoring institutions like family that are very exploitative. And the other law that I wanted to draw attention to, and that will bring me to kind of, later on focus on it a little bit more, is on the Medical Termination of Pregnancy Act. And we've just a few weeks ago, the government has initiated amendments to this act, which are extremely problematic. And I will talk about it a little bit more, and also talk about what we are doing in terms of advocacy and campaigns to draw attention to these issues. The other point that I wanted to raise is, which my slide says is the other political context. And you all might be following the situation in India, and we've had several concerns, one with the lockdown of a particular state in the north of India called Kashmir, and which has huge implications for healthcare, also for health workers there, putting them at great risk and not being able to provide necessary services. When I say lockdown, there has been internet lockdown, transportation has been curtailed, phones have been communication has been completely shut down. The other point I wanted to raise in terms of other political contexts is about our citizenship laws, which are really, you must have heard about all the protests and things that are taking place in India. Next slide, please. So given the situation, and in this slide pretty much shows a range of advocacy efforts that we've undertaken, both as an organization, but also as part of larger alliances, as part of the People's Health Movement and other movements. And I just wanted to say that each of these, I mean, it's not linear in any way, but each of these kind of feed into each other, and they have been very important at really challenging some of the context that I kind of presented before this. So when we speak about global advocacy, and this really has led to global and national accountability. And we can take the example of universal health coverage, the political declaration. Of course, the text and the language and the presence and of gender equality, social inequities, and SRHR could be much stronger there. But given the opposition which Eleanor talked about, that we've actually managed to get this far was quite amazing. And this document is only the beginning, and it's not just a document, it's a tool for us, for our advocacy. It's very important as a basis or as a tool that we can use to hold accountable our countries and our regions. The second point, so that was what I meant by global advocacy and how it can lead to global and national accountability. And that global advocacy was made possible by a huge alliance of people who understood these issues, believed in these politics, and came together to demand what we did, whether it was about gender equality, SRHR, or universal healthcare. At the national level, we've used national advocacy to inform global advocacy and accountability in many, many different ways. For example, if you take the example of, say, access to healthcare, we've used mechanisms such as CEDAW. We've used mechanisms like CESCR, which through national advocacy processes, through building on alternative reports, we've tried to kind of really use the global spaces to also consolidate our advocacy efforts for accountability in the country. Because oftentimes, and as I presented earlier, just by signing on or endorsing a particular a political statement or a declaration, the country obviously is not really necessarily feeling accountable to it. So it requires, and that is why I guess we're all here, constant pressure to hold them to account. And I think the national advocacy really allows that to happen. And when I say advocacy, it means through policy dialogues, through providing of, creating of knowledge resources that can be disseminated widely so that we can build public opinion of people, so that the state governments as well as the union governments can be kind of challenged and held to account on a range of issues. We also feel very important, that we also feel that cross-movement and alliance building is very important. I'll take the example of UHC itself. While we were involved with the Alliance for Gender Equality and Universal Health coverage, we are also part of the People's Health Movement, and this allowed us to kind of really understand issues from different perspectives and inform our conversations as part of these different alliances. And we find that this strategy is extremely important to build our own understandings on different issues, but also to kind of really build the solidarities and synergies, which today become very important. Most issues that we are all, from the presentations previously by Shaikat and by Faridah, I could make out that a lot of issues are very common across our countries, and therefore global solidarities become extremely critical.
Thank you, Deepa. Sorry to jump in. I want to make sure that we have enough time for Q&A. I really appreciated hearing about the global and regional as well as country solidarity and working with alliances, as well as how you're working in India to use the political declaration as an advocacy tool, looking at the legislation that's moving in country. I think these are great lessons that we can unpack a bit in the Q&A, so I'm happy to move there. And the first question I wanted to direct to Eleanor and Shaikat. There have been a few questions in the Q&A about the status of transgender women in relation to UHC and physically disabled people. Questions about what action should be taken to ensure their inclusion and what are governments doing to ensure inclusion of transgender and physically disabled women, looking at Bangladesh as an example. So perhaps, Eleanor, you can give perspective from the global level, and then Shaikat, you can give some comments related to Bangladesh.
Yes, thank you so much, Courtney. I think that's a really important question and critical to all that in terms of global level advocacy, where so much of what we're doing is awareness raising and working within the language of international policy. One piece of it is the inclusiveness of the language and ensuring that we're not always talking, or that we are not using gender binary language, saying women and men, but that we're talking about all people and all their diversity, all women and girls and all their diversity, and including, and specifically when we're talking about groups that may be discriminated against, calling out the groups that are most discriminated against, but being careful not, of course, to have any limited listings of people, because we don't want to leave anyone out. But I think critically making the space, not just the language of what we're putting into the policy documents, but making the space where we're having these alliances and coalitions open to transgender people is crucial, to have the voices heard and have people in leadership spaces, so that it's not being, that people aren't being talked about but are part of it. And they're very clearly, in terms of health, there are very specific health issues. And I think Deepa's point about the transgender policy in India, which I'm sure is similar in many places, can be really dehumanizing, and we need to call that out and make those changes. And very similar things also happen with persons with disabilities and women and girls with disabilities in terms of dehumanizing treatment and a lack of recognition of fundamental human rights in terms of being able to exercise bodily autonomy and be ensured of that decision-making right. So I think, you know, we also need to ensure that in our global coalitions, that it's a space, a safe space where we can all be called in too, to be ensure that, to be clear that we are being as inclusive as we should be, and to always be learning amongst ourselves as well.
Thanks, Eleanor. Shaikat, there was a specific question about this in the context of Bangladesh, and I didn't know if you had any comments to share.
Thank you, Darcy. Thank you, Eleanor, for putting light on that as well from international perspectives. I'm just quickly giving two updates that following the UN Convention on the Rights of the Person with Disabilities in 2008, which was effective in 2008, and Bangladesh actually adopted that in 2013 through the Disabilities Rights and Protection Act. But at the same time, there is a lot of other strategies are being planned. For example, the mental health strategies are just being, it's like under construction, what we can say. And it just started in last November. But the struggle that the person with disabilities still in the country are facing is the access to the health facilities, even the physical access, or we can say like the virtual access is not even familiar with the general population. But what we are concerned much of is like even the physical access is not. So we are advocating with the Ministry of Health, and at one of the events that we annually host is the Bangladesh National Youth Conference on Family Planning. And through that, the persons with disabilities, especially young women and the young persons with disabilities, who, they try to come up with questions to the Director General of the Family Planning Department, and are your facilities disabled friendly or not? So they committed to make sure that the facilities are the government facilities are disabled friendly, but it is taking a bit time, because like they have all these paperwork, they have all the strategies, but they have a lot of excuses as well. But we take some of the actions positively, because the Director General of Family Planning is immediately took step to make their offices accessible, and also they ordered that in many of their facilities that do not have that ramps to for the disabled persons with wheelchair users, they can now use them and then access them. So there's some of the advancements out there. I also saw the question on the transgender rights, and as we know, like the Bangladesh government has given enacted in 2013 as well, like there's a Transgender Rights Act, which gives them a legal status of the third gender, but there is a lot of controversy on the third gender thing. But they still have the third, or the numbering thing is really questioned. But the government tried to, I think the government tried to make sure that the transgender population has a legal right and recognition, within the borders. So SERAC-Bangladesh is advocating since 2017 that all the policies in the country, all the spaces that follow that law and the gadget that the government had in 2013. So this is what we're advocating with. Thank you so much.
I wanted to send the next question to Faridah. We've had a few questions about engaging religious leaders, especially for SRHR topics like comprehensive sexuality education. Some of our participants have noted that in Kenya, implementing CSE has been hindered by the objections of religious leaders, and that in countries like the United States, this also remains a problem. So Faridah, do you have any comments about how in Uganda your efforts have been able to engage religious leaders, or what strategies you might have taken?
Yeah, thank you very much. Engaging religious leaders wasn't very easy for Uganda. And when the church came out to tell us that, they shouldn't teach sexuality education in the Catholic founded schools, it was a big backlash. And it set a stumbling block for most of the advocates. And, we went back, we had to go back to the drawing board and, bring them on board, explain to them, because they were very concerned. At some point, they're like, why is there content for 3-year-olds? So we had to explain this according to the age appropriateness of the different stakeholders that we are going to be, taught about sexuality education. I must say it wasn't very easy, but with a lot of engagement, sometimes the more you provide the information, the more you engage, the more people come on board. And, at some point we had to also utilize, certain verses in the Quran, in the Bible, to be able to justify why certain things needed to be done differently.
Thank you, Faridah. That was helpful. Deepa, there have been some questions about insights on approaches advocates have used from a demand side to promote gender equality and financial protection with UHC, noting particular challenges for rural women and those in the lowest quintile. I was hoping you might be able to reflect on this question, as well as the equity dimensions of UHC and how you've been advancing those in the context of India.
Thanks. So yeah, it's a very important question and an important dimension. I think oftentimes when we really talk about healthcare, we don't adequately look at or understand social equities, which includes, of course, gender inequity or equity, but also other intersecting inequities on the basis of class, caste, race, or tribal identity, disability, etc., sexuality, etc. So in India, a lot of our work, and I was trying to say that during my presentation too, is one of the things that we've done is to try and amplify the voices of women and girls and others who are from these communities, so that their access to healthcare, or the barriers to healthcare, or the whole understanding of health, which is not only about healthcare, but also the social dimensions of access to the various determinants of health are addressed. So this is done by really building evidence, for example, doing primary level research or secondary level research that can build evidence on what are the experiences of such communities in rural areas, but also in peri-urban and the urban poor in India, whose health indicators are almost as poor as people living in rural areas. So to really build evidence, to involve them in advocacy processes at different levels, and to really amplify these voices through campaigns, through creation of knowledge resources, information resources, so that all policies can kind of really take into account these different experiences that different communities face when they try to access healthcare or try to access different determinants of health.
Thank you, Deepa. And maybe for a final question, and I will open this to any of our presenters who might have a view. There have been questions about impact assessments. And for countries that have done impact assessments of UHC or other health policies related to access and promoting gender equality and SRHR, what did the impact assessments entail? And are there any recommendations for frameworks that have been successful with impact assessments? So maybe Faridah or Deepa, do you first have any comments on this?
I couldn't hear you very well, but were we talking about impact assessments?
Yes, my apologies. People have been asking about impact assessments of country implementation of UHC policies. What did they entail? And are there any recommendations for frameworks for impact assessments that have been successful? So Deepa, looking to you potentially, or perhaps Faridah.
Yeah, if Faridah wants to answer, otherwise I can do that. So, okay, so basically, I think the important bit is to one, that frameworks, a lot of frameworks that assess impacts on universal healthcare don't necessarily incorporate a gender lens to it. And oftentimes they also miss the lens of inequity. There are certain frameworks that are available. These are, I mean, for many of us who work on the ground and in certain contexts, we find that it is very important to build these frameworks in consultation with communities that we work with, and that really works well. So to really assess what are the kinds of what would be seen as impactful, and what would be processes to measure these impacts, how do we do it? What should be methodologies that do it without stigmatizing communities, at the same time really building capacities? These are all important questions that we kind of take into consideration when we draw up frameworks. I mean, I can't, I don't recall a particular framework that I'm immediately able to share, but there are frameworks which we find that we still have to build on. And the best ways is to really have consultations with communities to really consolidate existing frameworks from the context that you come from.
Thank you, Deepa. That was really helpful, and an important reminder that the best way to assess impact is really working with the people directly. We have many more great questions, but unfortunately we're running out of time. What we will do at Women Deliver is to work with the speakers who are able. Perhaps we can circulate some responses to the questions in writing when we share the webinar recording and also the slides later. So as we close, a thank you to everyone for joining today's webinar. We know this is an unprecedented time for public health advocates and decision makers, and we're really glad that we could use this opportunity to come together to look to the future and work together to build health systems that advance gender equality and girls' and women's health and rights. Of course, the COVID-19 pandemic shows us that now more than ever, we need to continue to press for strong, gender-responsive, universal healthcare systems. At Women Deliver, we think it's critical to continue to drive momentum and action for gender equality in UHC and fulfill the promise of last September's political declaration. We also know it's important to shine a spotlight on the COVID-19 crisis and the implications it will have on UHC and gender equality efforts more broadly. In this manner, as advocates, we're urging partners and decision makers in the UN, WHO, and in national governments to embed a gender lens both in the emergency work, but also in the post work in the social and economic recovery. We're also looking to partners like you on this webinar to understand how we can activate and support networks as well as collective efforts to mitigate and tackle the current health crisis. We also hope to be coming back to you soon with a webinar specifically devoted to gender in the COVID response. The webinar would help connect and inform global and public health advocates, as well as decision makers from around the world. So please stay tuned for details. In the meantime, we thank you for your strong commitment to gender equality in UHC, and thank you to all the speakers for your really thoughtful presentations today. Our collective efforts are needed to keep gender and UHC a priority. So thank you for the work you're doing and the work that you will all continue to do.